Journal. It is my pleasure to introduce to you this afternoon Dr. Gerald Harmon. He is our next presenter. He is a family of medicine physician who currently serves as interim dean at the University of South Carolina School of Medicine in Columbia, South Carolina, of course, and he will be discussing Association's approach to medicine and proactive care. Please join me in welcoming Dr. Harmon.
Thank you, Jennifer. Good. This is me. I am a former officer of the organization, Southern Medical. I just stepped down as being chair of the finance committee. And so one of those things that we just heard about, I had my conversation with Dr. Burroughs Ray and Dr. Jackson talking about on the last question saying, you know, how come the doctors don't get involved in organizations and leadership and administration? Well, but we want to see patients, or we want to do research, or we want to teach. We don't want to do that administrative open person stuff. If we want to be an administrator, we've gotten a master's degree. In reality, you have to do it. Someone has to define the committee chair. Someone has to be an organized medicine. Someone has to make the decision about our operating healthcare system. So everything I just heard resonates with me. To resonate with everybody in this room, because here we are in organized medicine. So I'm really preaching to a congregation that's already drinking, mixing a lot of medicine, already drinking a fair amount of Kool-Aid. I mean, you're here. You're doing something outside of your normal team post teaching and research. Thank you for doing it. Many of your debt and all of us in the profession, in debt to those of us who are taking some leadership role. I got my little ditty bag when I showed up here. I've got something that I consider to be a little age discrimination. The word age is just a number by Dr. Patel, and not a best copy. It's just for me. But as I look around and say, I hear, and I read some of it in there, it's for all of us. So when I'm here today, what I'm going to talk about is the organizations and associations approach to medicine and proactive care. Background, I just finished 10 years on the AMA board. I was chairman of the board and the president of the American Medical Association. Just stepped down this year, earlier this year. Before that, I had 35 years in the military, organized medicine in a different environment. Wound up with an office at the Pentagon and assistant surgeon general there. So I've seen a lot of stuff, but I've also, in the midst of all of this, been a practicing family doc because the last 30 years, 25 years of my military career was in the reserves through National Guard. So I got to be a doctor in frontline medicine, small town America, every day seeing patients, at least many days when I wasn't already doing my other job, for seeing patients. For the last 2.5 months, rather than retiring, although I thought seriously about it, I was given the opportunity to be a dean of a medical school. One of the things I have a real fault about is saying no. And I hear that among all of you in here. You don't say no well. And that's okay. It can be a little baggage, but it really gives you the chance of bringing your perspective, your thoughts, and maybe your secret sauce to the almost overwhelming number of problems we find ourselves facing. I'm going to talk about what I think the associations are, including my previous one, the AMA, and my previous one, currently still the Southern Medical Association, and many organizations, whether it's county or state or city or town medical organization, even group practice. This is what we as physicians, who by our very nature are leaders by. A lot of you say, well, the leaders are doing this, leaders are doing this. Hopefully, folks, and that's what, you know, really, we're all leaders. That's why we've got the degrees after us. Anybody in here doesn't think they're a leader, try to sneak around a small town when you're a doc and do something. You automatically recognize the words mean things. So you actually have a belief pulpit without realizing you do. So anybody in here says, I want to be a doctor without being a leader, that ain't going to happen. You're already a leader. You're recognized as someone trusted among the most trusted professions in the entire world, even after the COVID pandemic, even after the height and the lack of trust in public institutions, even though there's some of us that lost a little trust because of, I guess, a pandemic misinformation and mistrust that we just experienced, even before we had COVID, we're still among the most trusted professions, right up there with the clergy and the military. and way above Congress and organizations and our federal institutions and the press, things like that. So we are leaders and we are trusted leaders. Wear that mantle proudly, wear your name badge proudly, put DO going to be after your name and understand that means I'm a leader. Just remember, it also puts you in a pretty high calling. When you think about leading and giving your opinions, make sure it's really, I would say scientifically based, if not peer reviewed, but you really give a thought. You heard about that too from our previous speakers, and they say, be mindful, practice mindfulness in everything you do. Now, I'm not going to give you the secret sauce. I'm just going to give you what I'm seeing, what I think will be our currently our present, maybe our future, about being proactive and approaching it from organized medicine. This is my background. As I said, I'm currently an interim dean, which means since I didn't have any academic background, I had to negotiate the title interim dean. I don't know that that means it's not really acting. I really am the dean, but I didn't want to have the full appellation of academic dean without giving the chance to prove myself, because I could have some standing, maybe some trust in the real deans who's been a career in academic practice. My academic reflection has been clinical graduate, which means I never got paid to do academic stuff. So now I'm actually doing it. I'm trying to earn that role. I am excited about it. We have a medical school. We have 100 students a year. It's been in existence 47 years. We're going through what we're calling LCME site visit in the next year. Those of you who are not in academia, that's your every 8-year stamp of it, keeping the doors open. So it's a big deal, a lot of pressure on them. Very complex, over 100 elements they bring to the inspection profile. And you have to spend 18 months getting ready for it in order to be ready for it. You can't just say, all right, we got an inspection next month and get it done. So it's very rigorous, and I'm learning all of that as well. The days of a physician simply showing up to work, taking care of the patient, going home, that ain't here now. That's long gone. Anybody says, I just want to be a doc. You might have wanted to be a doc, but you can't just be a doc anymore. Just can't do it. Doesn't work. You hear it from my colleagues, you hear it in your day-to-day work environment, you hear it from your neighbors, you hear it from your colleagues, and along for the good old days. Physicians in training don't recognize that, but they do hear it from somebody who's seen you, the mentors and practicing docs, and they go in. One of our preceptors will say, you may regret your choice of medicine. You don't need a discouraging word. This isn't what I'm here to tell you about. Is one of the reasons I took this job to be an educator and a dean is because all of you physicians in training, we owe it to you. My generation and those before and behind me owe it to you to make sure your career choice to be a doc, one of the most exciting, rewarding opportunities you've ever made. Now, you understand that the days of just being a doc going to work and taking care of the patient going back home, they may be gone, but better days are ahead. You can deliver. We heard at lunch about the promise of tests to predict the presence of malignant disease. Think of all the treatments we have. I've got patients now alive with 2 or 3 different types of cancers that are metastatic. They're still getting disease-modifying agents, and they're still working. They've lived long enough to be in a wonderful area of technology and discovery and application. Think about the telehealth we're able to do. Think about remote working, going from home, not even and being able to see patients over the internet, give them care. Telehealth in the ICU, robotics, augmented intelligence. The things are available now. It's incredible, and the promise is even higher. These old days are gone, but better days are with us and even ahead of us. All right, this is, I've been talking about organized medicine briefly, but I've been talking about the last couple of years. One of the solutions for physician burnout is getting together, decompressing, maybe having a post-event debrief, but you got to have it with somebody besides yourself. It's really boring to think it through, because then you kind of just reverberate. You even get a little bit more deliberative. You heard some of our previous speakers talk about talking to people, talking yourself off the ledge, encouraging yourself to reflect, be deliberate. I think the new word is intentional to do that. So 175 years ago, we founded AMA. What, 117 years ago, we founded this organization. Each of our organizations are over a century old. Think about that lineage, how much we've learned, how much we've taught each other, how much togetherness we brought together for ourselves. And at the same time, the diversity. Look around this room. You know, 100 years ago, 175, the AMA was a racist white man, a Protestant organization. Didn't have any idea that we weren't diverse. I mean, we're the AMA. Think about where we are today, the wonderfulness, the wonder of being in today's military, today's academic environment, today's practicing healthcare environment. 54% of doctors are women. 100 years ago, it was 0.01. I mean, it wasn't very much at all. So we're in a great profession, a great opportunity. Organized medicine is taking the lead. Perfectly so. You're going to need 130,000. I'm going to talk about work. My topic that I'm going to talk about basically is not about burnout, not about the promise of medicine, but I'm going to talk about the workforce. If you ask me in any interview, ask me walking down the street, talk to your neighbors, talk to your patients, what do you think about healthcare? It's wonderful when I can get to it. My little hometown paper down in Georgetown County, South Carolina, had a letter to the editor this past week, and it said, emergency room issue. One paragraph, letter to the editor. It said, dear editor, I went to the emergency room the other day at 12 o'clock. I left at 4 o'clock and never saw a doctor. My stomach hurt. Never got to see a doctor. I signed in. I looked online and it said the wait was 34 minutes. He went to the emergency room. He went to the window and there was a note in the window. Sign in here, put your date and time, and we'll get back to you. Put your phone in. There was nobody even there physically to take care of him. I mean, not a human being, not a voicemail, not a electronic record or anything. You had to write it down with a pencil, put it in, and make sure you could actually write it. I suppose you couldn't do that. And he went back to his car because there's nobody else in there. He said 3 hours later, nobody contacted him, so he went home. And he didn't get that sick. But our healthcare system is failing that person and everybody else. Because you wouldn't know how to write. 10% of my patients where I live aren't really functionally literate. They can't read or write. It's a small town America. I have to remember that when I talk to somebody. They've been my patient. I've been back for 40 years ago. We know each other. We can communicate. But I can't write things down on my prescription pad or something and give it to them. They're not going to every now and then they'll remind me. So, I'm going to put this little X here. You go to the drugstore, they can take it. Just think about the folks who can't get this stuff. Not only that, but how about people that have knowledge and still try to find a family done? Now that I'm dean of a medical student, so far this past week, I had 4 people calling me up and said, hey, Jerry, I've got a hearing problem. I can't find an ENT doctor that will take me for 6 months in my past. They've been in town 3 months. They haven't been able to get them a family doc either. They can't get to the system. So their default is going to emergency room. There's a 3-hour wait. We're failing our patients and failing the profession because we're not having this stuff. This is today, not 130,000 in the next 7 years. And it's complicated by a lot of factors. Complicated by aging patients, aging workforce. Look at me. 5th decade of practice. And burnout. We already had a good discussion on burnout. A couple of numbers. Let me just talk about, this may be a bit of an eye chart. This is the most eye chart slide I'll show you. The workforce concerns that I'm going to discuss today and that bother me a lot, aging physicians. We know that 20% of current doctors are going to retire in the next 2 years. And that's across the age. Whatever, not always somebody. I'll tell you about the numbers of those that are 55 and older, those are 65 and older, and another slide. There's no meaningful compensation. Whether you're a leader, whether you're a C-suite person in a corner suite, whether you're an administrator, whether you're chief financial officer, whether you're individual practice or whether you're group practice, compensation, there's been no meaningful increase in provider compensation, physician pay, nurse practitioner, advanced practice provider. Compensation has not increased in the last 25 years. There's still budget neutrality for Medicare. Those of you who are learning in the learning process, medical students, fellows may not understand it. Those of you who are practicing doctors or administrative doctors, the Provider pay is budget neutral. Hadn't gone up. We've lost money. Talk about that in another slide. Just the Medicare, just cost of living, it's been relatively flat for the last 25 years. We've lost about 25% of income, 1% a year. I don't see any potential of that getting any better. Not only that, but because of what's called budget neutrality, if we allow more of one specialty to get compensated fairly, say we decide to pay family matters, pediatrics more money, it has to come out of some other specialty compensation. A couple of years ago, in order to pay for more, for, let's say, rheumatology or chronic care or something, cardiology and other compensated fees got reduced substantially. To go to your cardiologist, remember about a decade ago, when you got the fee stuff, just because they had to, not because you did anything less before. But the budget neutrality, which means Medicare fees cannot, you can't take it from one specialty without, you can't give it to one specialty without taking it from another. That's the way the law set up. You have to change federal law to make that work, and they're not interested in changing federal law. And it's aggravating. Graduate medical education. Almost 2,000 medical students graduate every year and can't find a PGY1 slot. You all know that when you graduate a medical school, you've got a doctoral degree, an MD or DO. You don't have a job. You might get a license, but you can't practice. You get a temporary license. Start. You can write prescriptions and do things, but you can't get paid to do any of it. You got to have a job. Which means you have to get PGY1 internship, first year residency, after you get your degree. We graduate a couple thousand more every year than we have slots for. And that's federal law also. Tied to Medicare. Talk about that. I can change. So it's frustrating, sure. Digital health. What we must do is use more digital methods, online interviews, virtual care. We did a little bit. We did a lot more during COVID than we ever had done before. Mayo Clinic did a study, said they increased their use of online visits by 13,000%, which means they barely were doing it. They did a lot. And all of a sudden they said it worked pretty good. 90% of the patients like it. Okay. 80% of the providers use it now. They didn't use it before. So we need to use more digital health in order to meet this workforce. We also need to use augmented. I think it's called artificial intelligence, but I like the word augmented because artificial lets you think about Terminator taking over the world. You know, I'll be Bob. But you know, artificial is something that I don't really think is artificial. It's augmented. This is the intelligence inside our squash here. I mean, we're the ones that invented all this artificial intelligence. So it's augmented. It augments the human intelligence. And I promise you, those of us in radiology, anatomic pathology understand, because this pattern recognition, we know the better we embrace this pattern recognition and augment it, the better our diagnosis result, and the better output is, and the better it is for patients and for our staff. So it doesn't really threaten to take away my job. I didn't chat with GPT to take away my HEP or my diagnosis, but I need to use it to my advantage so I don't have to get burned out on this die of 8,000 quits death that we talked about. And then prior authorization. We now talk about the burnout. Some of those things that burn us. Some of those chronic, I call it a dirty word, prior authorization. Whether it's prescription, whether it's radiology imaging, whether it's referral from various specialties, procedures, you have to get somebody's permission to do what you know is wrong. And sometimes you have to get permission to get permission. Now, I have to dial up or call up or fax somebody in order to be able to fax them again. So I got to get permission to ask permission. That's stupid, but that's the reality. If I'm lying, I'm done. You know that. You shouldn't have to ask permission to get permission. And that's the barriers they put up. All right, let's burn it. We talked about it. We heard a whole series about it, and they were spot on. They were spot on when they talked about burnout. Almost 2/3 of practicing doctors have reported signs and symptoms of burnout at least every week. And it's not just, oh, I had a bad day. I mean, I want to quit the profession. I'm unsafe doing what I'm doing because I can't get over. These are the burnout issues that are addressed. You know, almost 42% of doctors about 6 months ago came out, and in a survey done by the AMA, over 1 out of 3, 42% regretted their career choice. If I'm a physician in training, if I'm a resident physician, if I'm somebody in my third year medical, and gee, yeah. Are these my mentors? Are these my teachers, my role models? Would all my staff and say, don't do it. You won't find it. That's a scary number. So we've got to do exactly what you heard from my colleagues ahead of us. We've got to change the system. We've got to worry not only about the canaries, we've got to worry about the coal mine that we're working in. Something not good about that environment. So recognition is important. And then we need to take intentional, deliberate measures to work on it. Let me take something. When you hear about this frustration with the career choice, since I'm a new dean, I went to listen to the Welcome to Medicine lectures by my associate deans and M1 first year medical student class. And I got there just in time to see the new students coming in, and they had 100 medical students in the amphitheater, and they were talking about my colleagues in there, all of the junior students but my associate deans were talking about welcome to medicine. You're going to be tested harder than you've ever been tested in the world. You're going to think you're in the wrong place. We're going to give you these questions. We're going to work you to the tipping point. I mean, all these horrendous things like you better put your armor on. You better wake up every day prepared to be slammed down and just beating them up. And I listened to him. I sat uncomfortably in the corner of the room and finally said, let's let Dean Harmon come in and talk and see what his approach was now. I didn't have to prepare to talk because I wanted to see what was going on. And I went up and I tried not to embarrass my colleagues, but I talked to these young medical students. I said, everyone in here just heard about how hard we're going to make it, how hard it is, how threatened you are with your career path, all the yada, 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 how difficult, and you're going to have some of the hardest tests, and you're going to feel discouraged and depressed, etc. I said, assuming that if that were all you're going to hear, be a little discouraged probably. Don't worry about, the implementation of the imposter syndrome. Am I in the right place? This really me. I'll tell you, everybody in here needs to understand. You're going to still be here 4 years from now. I'm going to hand you a diploma with my name on it because you've already made jumped the biggest hurdle. You got into medical school. How many of y'all found it easy to get into medical school? Raise your hand. Nobody did it. So you've already proved yourself that you can be a doc. It's my job to make you that doc. Not my job to scare you. Not my job to threaten you and to demean you and tell you your life can get hell over the next couple. But I need to understand, and all of us need to understand these things. Once they get into medical school, our job is to get them through medical school, get them whatever specialty, get them in the workforce, because they already are gifted. The rigor of getting them out of school. And it's not an artificial. Unfortunately, it's real. You can't make a certain number on the med test. You can't have a certain GPA if you don't have a bunch of successes. That it's not right for us to kind of make you into about because you're not that lump of clay. You don't have whatever it is that makes a good doctor. Focus, attention to detail, creativity, flexibility, intellect, motor skills, maybe. If you don't have that drive to be a doc, get into medical school, we're wasting your time. You need to find a career. Or you're almost on the bubble. You don't make it. We need to help you get there. We know that. You have that. But unfortunately, the way healthcare is, calling that it is, have other careers, military, flying airplanes, things like that. People really want to be a pilot. Sometimes they can't. I don't want to take $250 million of their tuition over 4 years. So I'm sorry, you can't be a doctor. That's what they have for the need. I can't give them a mortgage without a house, and I know they can't afford that house. So I shouldn't have it. Anyway, I would tell you that when we scare these young doctors in training, let's don't scare them. Let's pump them up. Just to make them understand. My job and my commitment to them is I'll make them stop. And I like for them to reflect honestly that one of their teachers, Dr. Carter, Dr. Harmon, or Dr. Jackson, or Dr. Gerald, because we'll be proud of them, and that's our responsibility to do my fiduciary duty for them and us as students in the profession. But anyway, having regretted their choice in the career in medicine, I don't want to hear that from these medical students. They need to know day one they're in the right place and they're going to be in the better. That's just my thought. Some of these numbers, I would say they're not right. It's actually by 2030, 20% of the U.S. will be 65 or older. Okay, don't write these numbers down, but that's an amazing number. 20% of U.S. And also 20% of the doctors are going to be that age also. We have an aging physician workforce, and guess what happens? The older you get, you have more burden of disease. That's not surprising. I use this when I teach my young doctors in training. Just a rule of thumb for patients, according to most family medicine doctors, and that's what I am. You pick up a disease or an illness or condition every day. Something happens about every day. If you're in your fifth decade of life, almost 60 years old, in your 60s, I don't count the first, you don't pick up much of it. But after that, from ages 10 on, you pick up that disease. By the time you're 20, you might have acne, you might have some skin disorder, you might have asthma, something like allergies. Okay, musculoskeletal. Now you had an athletic career, you got a bruised knee or something. Then in your mid 20s to 30s, you'll pick up mild dyslipidemia, maybe some asthma, maybe irritable bowel, something like that. And 40 to 50, you got hypertension, dyslipidemia. In the 60s, 90 million Americans pre-diabetic, 80% of them don't know it. You've got a condition. So if you think about it, somebody in the mid 60s has about 5 chronic diseases. A disease burden that takes a lot of docs to take care of. So with the aging of America comes a demand from us as healthcare providers. And we're aging too. So one of my jobs, our job, is to extend that runway for us. So that when you're 60s and 70s, you may have lost some of your hearing or motor skills or vision. So you may not be able to do vascular surgery without loops, or you may have developed a tremor or something that you can't sew as good as you could do. But we need to think about reconditioning you so that you become something that's not less valuable, but just as much needed. Maybe it's been a medicine specialist, maybe a 1-year training. But if you've been a trauma surgeon all your life, you don't think you have the motor skills or something. But you can still be a preventive medicine. You can be a nutrition advisor. I'm not demeaning my occupational medicine folks. Med is one of those specialties. We don't have any much of anymore. Okay? Occupational medicine is underappreciated, underutilized. You can maybe work in a large healthcare system, do occupational medicine. You're a physician, for goodness sake. You've got a postgraduate medicine degree, plus with all the training. So you can do that with maybe a year. And I'm trying to expand that role for aging physician workforce so that you don't feel, I might as well retire because I can't do neonatology anymore. I can't do maternal fetal medicine. You can do a lot. Extend your runway. That's one of the things we need to think about. You don't have to automatically step out of the workforce. And healthcare systems need to support that for you. The point I heard earlier from my Air Force colleague, look into being an administrator. Take that clinical role, apply your skill, your lived experiences to that corner office, because they're not teaching that in MBA school. They're not teaching what you understand, your lived experiences. Take a leadership role. Get involved early on. Compensation. Medicare pays for providers, ads, cost over 25 years. The budget neutrality, as I talked about, affects all spectrum. This is my AMA commercial. I'll tell you about that. This is a very graphic display of what's happened over the last 23 years. 2001, the consumer price index has gone up considerably high, but with a baseline of 2001 at 0%. Consumer price index is up about 70%. Physicians only up about 9%. Physician pay. Practice cost, Medicare economic index is up about 50%. So we just have not been paid fairly over the last 25 years. Unless we change that, we are going to have difficulty meeting our financial people out. If you're an employed doc, you may say, well, I'm not worried about it. My employer's got to deal with it. Well, your employer has to deal with it by cutting your pay, cutting staff. I hear that too. And then we'll talk about burnout. They don't cost staff. They'll keep you there because you're revenue generator, but they won't give you staff. Okay, you have to have physicians paid so they have enough margin to keep the doors open, to keep practice open, and also so people can have access. So they don't have to wait 3 hours to get turned away in the ER because they can't go to a primary care doctor. You know, in my community treatment, talk about primary care, we don't make enough overhead in primary care to keep offices open on weekends. You know, you can get to see a sports medicine orthopedic clinic where I live 7 days a week. You can't get a primary care doctor because the insurance companies pay for x-rays, stitches, and injuries and ultrasound therapy before they'll pay for thoughtfulness about diabetes, high blood pressure, dyslipidemia, behavioral health issues. So again, the revenue drives the opening and the access to care, but that doesn't help our underserved population that don't have the opportunity to get seen except on the weekends where they're not working. And the doors are all closed in the week. A lot of healthcare demographics and operations have to close. Workforce issue. We talked about graduate medical education. This past year, in the summer, let's say the spring of match day in March of 2023, mid-March, we had 43,000 medical school grads and just over 40,000 GME slots available. That's match day 2023. We had a lot of happy residents, a lot of happy residents, and a lot of small but substantial number of docs who couldn't find a job, who had to go scrambling around. A lot of people, when I go to my state legislators, I go to my communities, I go to public hearings, they say, we don't have enough doctors, let's open up some more medical schools. I'm okay with opening up medical schools. In fact, they are opening up about 2% more MD allopathic schools every year, about 4% more osteopathic schools every year are opening up. But that's not helping the physician workforce right. Until I fix the GME allocation problem, I've just got more frustrated MDDO. I've got to fix it. It's got to be handled by changing the Balanced Budget Act of 1997, which is the basis of graduate medical education. Some of you may know this much better than me. Feel free to correct me if you have to. But basically what happens with the Balanced Budget Act of 1997, the number of graduate medical education slots fixed in established residency programs. So you cannot expand an existing residency program under Medicare funding. You have to open it in another location with new Medicare funding, and it's only good for about 5 years to become self-sustaining. And that means existing programs like where I am, University of South Carolina, they have GME slots that they established before 97. And if they open up a new one, it has to be in a smaller community that doesn't have infrastructure. So you do it at risk for the smaller community-based system. And that may or may not return on your investment. And these healthcare systems and communities in America are losing money. Several smaller healthcare systems closing over the last couple of years, and maybe 1,000 more still at risk of closing because of declining reimbursement and increasing costs, including their workforce costs. The margins are going to negative, and you can't keep the doors open. If you're involved in administrative healthcare financing, you know that. It's a threat to all of it. This threatens underserved American, small town America that I operate in. However, if we can change the balanced budget, we can change that, we can open up more residency slots. We already have the infrastructure at a reduced cost because I already got faculty, already got buildings, already have community. All I have to do is maybe increase some of my residency slots by 10% there, 20% there, without necessarily increasing my staffing, maybe a little bit, but I can do that without having to purchase up front a whole new infrastructure. You know, I have a workforce shortage. So I don't have enough GME instructors to start with, and you got to have faculty, and they're already set for their productivity. So if you ask them to tail their productivity by taking on the teaching role, they say, "Hey, I'm already really keeping the doors open." So it's already it's a difficult situation that an easy fit. There's a reduction act, the Balanced Budget or Medicare Reduction Act of 2021 that a lot of organized medicine supported, including many of the specialty boards, AMA, many of the organizations. I can't speak for the SMA, but I can tell you that you're in the same boat. So the SMA would clearly want all of this to happen. And I'm not currently on the board of the SMA, I can't tell you. But it would fund 14,000 residency slots over 7 years, give us 2,000 a year, and that would make up for the gap. If they would do that, we would have a freer market space operating and expanding our existing residency, and be able to take these new graduates from medical school and put them in this fashion, fit some of the physician choice. Now, beyond that, the other thing we have to talk about is other ways to expand our workforce capability to meet the demand. Talk about telehealth, digital health. We had an exponential increase with the COVID pandemic years since 2020. 80% of doctors use it now, 90% of patients like to use it, and it's approved by CMS to give you the same compensation as an in-person visit through the end of this calendar year 2024 coming up. Now, I'll tell you, the data shows that it costs us just as much to see a patient electronically, believe it or not, it does in person. You think, oh, that doesn't make sense. And I got to have gowns, I got to have gloves, I got to clean the room out, but set it up, have the technology to spend time. Someone has to, it's just like getting on the internet and it's a pain. I've tried it. Someone has to take extra time to do it. So it takes that extra time, and that resource time is money, and it costs money. So it does cost us just as much to get the telehealth. So we ought to get compensated just as well, and the data shows we get the same results for most of the time. So that's another way to continue expanding our workforce without graduating more GME slots or producing more docs or nurses or non-physician providers or x-ray techs. We can do more digitally electronically. We need to take advantage of that. Digital health also includes augmented intelligence. We talked about that, where it's not a threat, it's a tool. It's like anything else. It's a tool to be used. There's a good article published online just in past May. You can look it up, but what it said, we talked about ChatGPT. You know, ChatGPT is quite impressive. We've had some data. If you want to Google around, look at it, it's out there and find it. It can pretend to be an answering thing, or pretend to be a healthcare interview. There's a good one online that you can look at, and the studies actually show that they seem to be more humanistic, with more of a sense of humor than an actual person getting an interview. I mean, it picks up on nuances that the patient's question, and it gives reliably good data. One of my colleagues, when I was saying, you know, in an ideal world, if I were going to use artificial intelligence, I'd go to the exam room instead of having to work on my digital record, pointing and clicking and looking away from the patient. I could examine the patient, get the history, make a recommendation, say, you know, it sounds like to me, and I would dictate kind of as I would, someone would pick up the dictation. I'd say, as I look at you, I see you've got a rash over your anterior thorax, and there appears to be maybe there's some infection there. I suspect you've got some folliculitis. Might try topical antibiotic if I'm worried about it. You know, I can use the lab work. I might get CPC with the test, maybe a count that helps out much better. And my artificial intelligence ChatGPT is documenting all this and ordering all the tests as I leave the patient through. And I'll say, I'll see you back in a couple of weeks and probably some topical clindamycin gel, give you a couple of refills. I want you to have an appointment to see me about 3 weeks, see how it works out and look. Call me, got any questions? You know, any questions, they leave, and then I would automatically generate. Well, I did that for my colleague, and he produced exactly what I am using ChatGPT. So I'm kind of believing that. But right now, if you look at it, it really has large-scale language, has an incredible opportunity right now. We need to embrace and not be threatened. When I talk about embracing things, one of the things I'll also talk about is prior authorization and electronic record. You know, we heard this, someone a minute ago said they were almost clicked to death when they had to do something with an electronic record. I found that to be interesting because I get upgrades all the time on my electronic record. You know, that's an electronic record upgrade is an oxymoron. There's no such thing as it's an electronic record speed bump. You know, it doesn't upgrade, it makes it worse. You know, first you can't log on, you increase your number of clicks, I heard that, and it becomes an impediment to delivering patient care. So there's no such thing as electronic record upgrade. You know, the average doc, we've got data at AMA, says the average doc spends 56 hours every year just logging in to some electronic record. That's an entire work week. And that's just non-value-added wasted effort. You talk about something that causes burnout, that impedes productivity, makes you wish you were going to die. Electronic record. And it's not just about electronic records like Epic, ECW, Medical. It's the entire electronic platform. Getting electronic records, getting power, validating a patient's insurance, looking up a data point you want to look at, checking on the form. You got to go for 4 or 5 different electronic record platforms just to do one page. ChatGPT may help us with that. So you have to embrace it. You have to make it better. You need to make it a tool and a utility versus an impediment. Getting into the office suite where we make that decision is where doctors need to be. The electronic records are made by non-physicians. It's done to collect money. You recall, that's what drove it. It's done revenue cycle generated too. Now it needs to be an operational. It has that opportunity. It's getting better with ChatGPT and large language models, but it still can be embraced. There's no true interoperability. You know, we talk about a high-tech accent and these records need to be electronically interactive. They're not interactive. One platform might be in Spanish while the other was in English, but you have to have an interpreter to make sure the data is safe. That has to be something only the federal government does. We need to hold them accountable to that high-tech. We need to have true interoperability so that you can share data patient. And finally, prior authorization. The average doctor spends 41 prior authorizations a week, 18 hours of his or her staff time handling prior authorizations. Not just prescriptions, benefits for X-ray, benefits for procedures, benefits for control. It is insane how many prior authorizations. And you have a lot of mine, 2 or 3 of them, I have to get permission to get a fax. And a fax in today's world, you know, some of the resident physicians don't even know how to do a fax. I asked him on rounds to say, hey, do you fax that over to the pharmacy? Well, Harmon, I don't know how to fax. I can take a picture and text. You know, or you hit the get a wrong number, you get that scratchy, whining sound. Residents don't have any idea what that is. I'm not forgetting the wrong. You know, the fax sound. And the residents in here will know that, I promise you. So this prior authorization is a dirty word. And over 90% of docs report at least the sub effort where care has been negatively impacted. And 80% of the time, someone has just given up on whatever they were trying to do. The patient just chose not to get the care. They couldn't get prescriptions. They couldn't get a treatment or an x-ray. They said, screw it, I'm going to get well on my own. So it is a huge impediment for patient care. I know I've kind of worn you out a little bit about this, showing you some slides and data, but all of these things can be done better. It requires legislative change. It requires the voice of more than just me, one person. The SMA has to do it. The American Board of your specialty has to do it. Your specialty society has to get involved. Your county, your state society. It can be done legislatively at the regulatory body level of the state, your community, or the nation. We need to stand firm, and we need to make sure all these impediments that cause burnout, cause physician dissatisfaction, that are non-economically sustainable. The best way to do this is through a large group, like an organization, to get attention, because we're all voters. We all make a difference at the regulatory agency. And without that, we're going to be kind of just pawns in the system. You have to have an active voice. You have to make sure your voice and your stories are heard. Stories catch the attention of different things. Media. Story in the media is a whole lot better than 1 or 2 voices, maybe a letter to editors. Write some editing. Get involved. Be intentional in your estimation and your request. I open myself up to questions, comments, advice. I want you to know how much I appreciate doing this. They'll throw the microphone to you. They'll throw that at you. I was at a meeting last year and they talked. But has anybody got any ideas or questions that I haven't addressed about this? I'm open to this, but there are ways to get this done. We have to change the rules. We can't just change 1 or 2 individually. I've heard before from my predecessor, like the Burroughs Ray, Robert Jackson. It's the system, it's the coal mine needs to change. Let's work in that. We're working in the coal mine, but they can't do it without us. So let's ask them to change the coal mine. We can make it work. Yes, ma'am. Doctor. Donna, they do that, and I'll tell you, all of you who get a chance to work with physicians in training with us, medical students, residents, doctors early in their career, make sure they understand that. I know we say, oh, that's easy said, Harmon, but I've got to document because if I don't get documented, I'm going to be on the naughty list and I'm not going to be able to submit the bill. We have to change that. We have to tell them that's where the chat GPT, the AI can make a difference from. We need to understand it. But the other thing is they can actually do it without looking at the computer. They really can. Okay? I've had a lot of colleagues here. The easiest way is look at the computer screen, but they can make a difference. Okay? I don't even take the computer over learning. I really don't. I just take a piece of paper. If I don't have a piece of paper, I write it on paper towel. And then I really do. Sometimes the office I might work in doesn't have paper, even though I have a paper mill in my town. They won't have paper, so I write it on a paper towel. If they don't have a paper towel, then I go out, excuse me, I'm going to go get a piece of paper. You have to be something, you have to look at the patient. You have to do that, and you have to take notes. I know it. Well, you're not, I know it. Let me tell you, all of us are as guilty about this, not just the young doctors and the family medicine doctors and the office. Some of my ER colleagues, many of you may be emergency physicians also, won't see a patient without a CAT scan ahead of time. I mean, they won't. You come in with belly pain in my emergency department, for two of them. The checklist is involves get a CAT scan, not examine the patient. Plain as abdominal pain, their first checklist is CT scan, yes or no, even without doubt. I mean, you understand, just the radiation is 100 pounds out of a chest X-ray. You got to at least examine the patient, please. If we're doing it for this productivity mentality, that's where you have to be in the corner office, changing the problem. Good point. I mean, yes, ma'am. Question over here, somebody. Comment, advice. The data does show scribes increase your productivity by 23%, your satisfaction by 50%. You have to convince, and I've had to convince my administrative offices, they got to invest in scribes. MAs, you heard that data point. The scribe improved, when you saw the presentation by Dr. Burroughs, it improved dissatisfaction from 53% and reduced it to 13%. So 75% improvement in provider satisfaction by the use of an MA, a scribe, someone else to do the computer typing work, whatever it is, electronic. That's a very easy, relatively inexpensive. It takes, you got to pay an FD for the scribe, but you get multiple times the return on your investment productivity and burnout satisfaction in the government. Very good point. I love scribe. And the emergency room is using that too. So that now they can take time to examine the patient versus scanning them. Good example. Yes, ma'am. Well, you know, that's one of the issues that we're going to have to budget for. You're exactly right. But remember, we had the budget for electronic records. We had the budget for bandwidth, all the things. That's part of our investment. And right now it's an expense. And when I have to sell my budgetary team and my planning team, I've got to cut it off with, is that it's an investment. It's just like building a new building, like building a future parking facility. We're going to grow into that need, especially in the areas of America, like we live in the Southeast, where people are moving. Okay, South Carolina has 1 million more residents And the last 20 years, and they have a 25% increase in our population. In the year 2000, we had 4 million South Carolinians. Now we've got 5.2 million 20 years later. Our entire infrastructure is destroyed. Not only medicine, education, stormwater, all that other. But we've got to invest in them in order to meet that population. Yes. No, I can't. I'd be bragging if I told you what it cost to check. Or AI. AI is such a broad spectrum. Large data mine, man, it's called in the vernacular. You may need some IT stuff. It's large data model. I think it's what it is. We have a school, University of South Carolina, data management school of information science, and computer science engineering. So they're, of course, collaboratively do some research looking into that kind of stuff. I got to go. Thank y'all very much. Peace out.